بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. My topic today is about differential diagnosis of female lower genital cysts, the common causes, less common causes, and rare causes, and the clue for the differential diagnosis and the clue for essential diagnosis. The key differential diagnostic issues, it is we divide these cysts according to the relation to the perineal membrane and symphysis pubis. Above the perineal membrane and the symphysis pubis, we have Gardner duct cyst, endometrioma of retrovaginal septum, and we have the urethral diverticulum, Nabothian cyst, Cystocele, and the Endocervicosis. Below the perineal membrane and the symphysis pubis, we have Skene gland cyst, we have Bartholin gland cyst, we have epidermal inclusion cyst, and we have subpubic cartilaginous cyst. The differential diagnosis, the common causes of these cysts include Nabothian cyst, Skene gland cyst, Bartholin gland cyst, Gardner cyst, urethral diverticulum, and Cystocele. The clues for common differential diagnosis: Nabothian cyst, located within the uterine cervix and can be single or multiple lesions in fibrous cervical stroma. Measures about few millimeter in diameter but can reach 4 centimeter or more. Intermediate or slightly high signal intensity in T1 and dominant high signal intensity on T2. Purely cystic without solid component. Distinguish Nabothian cyst from malignant adenoma malignum. We have, this is T2 sagittal MRI. We have hyperintense cyst within the cervical duct stroma. And this is the Nabothian cyst, minimally fluid noted in the pelvic cavity. Here, this is the same patient with axial cut, T2 weighted images. We have shows hyperintense cystic lesion within the cervical duct stroma of the uterus. Here we have sagittal ultrasound. We have two cysts in the two simple cysts appearing in the uterine cervix. Here we have sagittal T2 weighted images. We have multiple small cysts representing Nabothian cyst. We have also here, there is urethral diverticular cyst, and also we have a Bartholin gland cyst. In the same patient. Skinny duct, skinny gland cyst, a rounded or ovoid cyst located lateral to the external urethral orifice. It is inferior to the pubic symphysis and below the level of the perineal membrane. Ultrasound, it is anechoic low-level echoes. On the CT scan, it is a fluid attenuation. In MRI, it is variable in T1 and T2 signal intensity depending on the presence of hemorrhage and or a proteinaceous material, usually hyper-intense in T2 weighted imaging when it is uncomplicated. Here we see skinny gland duct cyst on axial T2 weighted MRI, well-defined cystic structure adjacent to the urethral meatus, demonstrating high signal intensity on this T2 weighted images. This is the same patient with skinny gland cyst, sagittal T2 weighted MRI, well-defined oval, demonstrating homogeneous high signal intensity cyst adjacent to the urethral meatus. The cyst, it is below the symphysis pubis, the level of the below the symphysis pubis. Bartholin gland cyst, it is located in the posterolateral vaginal introitus at or below level of pubic symphysis, inferior to the perineal membrane. Ultrasound, it is anechoic or low-level echoes. CT, it is fluid attenuation. On the MRI, it is variable T1 and T2 signal intensity depending on the presence of hemorrhage and or a proteinaceous material, usually hyper-intense in T2 when uncomplicated. Thin wall without significant enhancement in the absence of complication. Bartholin abscess will show thickened and irregular rim enhancement with adjacent inflammatory stranding. Here we see axial T2 weighted MRI image. We have hyperintense cyst at the level of the vaginal introitus on the right side, and it is uncomplicated Bartholin gland cyst. And here we see also another patient who presented with vaginal pain with an oval cyst. It is less signal intensity than the gel in the vagina, and this is the vaginal introitus and has almost the little bit higher signal intensity of the adjacent muscles. This is another patient, Bartholin gland cyst on the T2 weighted images, and we have a Bartholin gland cyst at the level of a vaginal introitus below the level of the symphysis pubis. The lesion shows in the intermediate signal intensity, and also we have two lesions in the cervix unrelated to the cyst. This is another patient. This is T1 weighted images. So after contrast, and we have cyst here, intermediate signal intensity on the right side of the vaginal introitus. The lesion shows thin wall enhancing but no enhancement of its content. Pus was aspirated from the cyst consistent with the Bartholin abscess. Genital duct cyst, a classically located anterior lateral wall of the upper vagina, above the perineal membrane and the symphysis pubis, commonly arising from upper vagina wall, though may be located distally as well. Ultrasound, it is anechoic or low-level echoes. On CT scan, it is a fluid attenuation. And on MRI, it is variable T1, T2 signal intensity depending on the presence of hemorrhage and or proteinaceous material, usually hyper-intense in T2. MRI, when uncomplicated, may be associated with another congenital abnormalities such as ectopic urethral insertion and unilateral renal agenesis or hypoplasia. Here we have Cartilaginous duct cyst on axial T2 weighted MRI between the urinary bladder anteriorly and the gel-filled vagina posteriorly. And here the cyst, it is hyper-intense in T2 weighted images. This is the same patient with carcinal duct cyst, and this is the cyst here, and this is the urinary bladder, and this is the vagina filled with gel. And the cyst, it is homogeneous high signal intensity. Urethral diverticulum, it is present as rounded, oval, eccentric, horseshoe, or saddle bag-shaped or circumferential periurethral cystic lesion, located at the posterior lateral aspect of the mid-distal urethra, above the level of the perineal membrane and the symphysis pubis. Direct urethral communication may be seen. High resolution, fat-saturated, post-contrast phosphosphenol T1 are extremely useful in identification of these diverticular neck. Anechoic on ultrasound, fluid attenuated on CT scan, and hyperintense in T2 weighted images on MRI when uncomplicated. Stones within the diverticulum may be seen in up to 5 to 10% of cases. Here we see this is the vagina, and this is the urethra, and this is the cyst. This is the urethral diverticulum on axial T2 weighted images, and it is presented as a horseshoe-shaped T2 high signal intensity lesion surrounding the urethra. Horseshoe shape, more prominent on the right side. Urethral diverticulum on this coronal T2 weighted images shows high signal intensity on both sides of the urethra. Cystocele, defined as abnormal descent of the bladder neck inferior to the pubococcygeal line on the midline sagittal image, either at rest or upon stress. Pubococcygeal line is drawn from the inferior aspect of a pubic bone to the last coccygeal joint, often associated with with additional pelvic organ prolapse or pelvic floor laxity. A small cystocele may simulate pelvic floor cystic lesion on axial imaging. Diagnosis is made upon recognized clear communication with the bladder lumen. As we see here, axial CT scan non-contrast uh, shows rounded lesion at the level of the vaginal introitus that it is filled with contrast. The sagittal CT scan shows that it is cystocele and it is below the pubococcygeal line. Less common causes, it is epidermal inclusion cyst, and the clues for the epidermal inclusion cyst, it is located at the sites of prior trauma or surgery around the vaginal introitus, commonly at the posterior or lateral vaginal wall. Episiotomy is a common cause. On the ultrasound, it is hypoechoic mass with variable echogenic foci without a color Doppler signal. On CT scan, it is homogeneous, well-defined lesion with attenuation higher than simple fluid, can be mistaken for solid mass. As we see here on ultrasound, epidermal inclusion cyst with the transvaginal ultrasound shows right labial majora lesion. It is hypoechoic with posterior acoustic enhancement. There is no blood flow within the mass, confirming it is cystic in nature, and it is not solid, and it is not solid. Here it is an epidermal inclusion cyst on the axial T2 weighted MRI and of the same patient. A well-defined lesion noted on the right side of labia majora. The lesion is demonstrated high signal intensity on the high signal intensity in T2 weighted images. Here the same patient, it is oblique sagittal view, shows well-defined high signal intensity lesion in T2 weighted images on the right labia majora, located immediately under the skin. And it is on the axial T2 weighted images in epidermal inclusion cyst on the right side of the labia majora with high signal intensity. Rare but important causes include endometrioma of retrovaginal septum, subpubic cartilaginous cyst, and endocervicosis. Clues for that: endometrioma of retrovaginal septum. It is centered in the retrovaginal region between the rectum posteriorly and the posterior vaginal wall anteriorly. Cyst with homogeneous low-level internal echoes on ultrasound. Homogeneous will defined structure on CT with attenuation higher than the simple fluid, around 40 Hounsfield unit. Hemorrhagic cyst with characteristic T1 hyperintensity and T2 shading on MRI also seen. Here we see endometrioma of retrovaginal septum on this axial T2 weighted images between the rectum and the vagina, filled with gel. The lesion is homogeneous high signal intensity on T2 weighted images. And this is the sagittal T2 weighted images of the same patient, shows that the cyst is here between the rectum and the posterior part of the vagina. The cyst, it is high signal intensity in T2 between the anterior wall between the anterior wall of the rectum and the posterior wall of the vagina. Subpubic cartilaginous cyst, midline rounded cystic mass located anterior superior to the urethra and posterior inferior to the pubic symphysis. Sclerotic and/or erosive changes may be seen in the symphysis pubis on CT scan or plain radiography. Hypointense relative to the muscle in T2 weighted images and heterogeneous hyperintense in T2 weighted images. Hypointense relative to the muscle in T1 weighted images and heterogeneous hyperintense in T2 weighted images. Thin enhancing wall with no internal enhancement. MRI may show direct communication between the cyst and the pubic symphysis. Endocervicosis, closely clustered cyst of virus size surrounding the proximal third of the urethra and may extend to the bladder, usually low signal intensity in T1 weighted images and high signal intensity in T2 weighted images. No solid element and no enhancement with gadolinium is noted. Here, sagittal T2 weighted images shows a cluster of cysts around the urethra. This is endocervicosis. It is the same patient with T2 weighted images, and some of the cyst is high signal intensity due to hemorrhage, likely. And patient with endocervicosis on this axial T1 weighted images, clusters of the cyst around the urethra, and some cyst has high signal intensity, likely due to hemorrhage. This is the endocervicosis, axial T1 after contrast. Shows a cluster of urethral cysts here and show high signal intensity due to hemorrhage, and there is no enhancement after contrast injection. Teaching points. Cysts of the female lower genitourinary tract are relatively common, may manifest with virus symptoms and complicating features, and may require different therapies. Their accurate diagnosis is essential to direct appropriate therapy. Incidental cystic lesion of the female lower genitourinary tract can be distinguished by their characteristic anatomic features and relationship. A key anatomic landmark is perineal membrane, which is positioned approximately at the level of the pubic symphysis and which divide the perineum into deep and superficial pouch. Skene duct cyst and Bartholin gland cyst are positioned below the perineal membrane and pubic symphysis in the superficial perineal pouch. Skene duct skinny gland cyst occur anteriorly near the external urethral meatus, while Bartholin gland are typically positioned at the posterolateral vaginal introitus. Urethral diverticular and Cartilaginous duct cysts tend to locate at the level of superior to the perineal membrane and the pubic symphysis. Urethral diverticular occur in the periurethral location and often surround the urethra. Cartilaginous duct cysts are classically arise from the wall of the upper vagina. Here, this is some of the cystic lesion of female urinary tract. It is relative to the pubic symphysis, inferior to the pubic symphysis. It is a skinny duct cyst and Bartholin duct cyst, and it is superior to the pubic symphysis. It is Cartilaginous duct cyst and urethral diverticulum. Thank you for listening. Hoping to see you in another talk.